Good afternoon and welcome. ISSA's tagline, Advancing Clean, Driving Innovation, represents our crystallized focus on ensuring facility decision makers see cleaning as an investment in human health, the environment, and an improved bottom line. One way we accomplish this is by providing tools and services that improve the efficiency and quality of cleaning, like our Cleaning Industry Management Standard, or CIMS certification program. CIMS is the ISSA certification program that offers a quality management standard for cleaning organizations. So please be sure to stop by our ISSA Resource Center, or booth 899, to learn more about this valuable program, and look for me. And now on to our session. I want to tell you a little bit about your speaker today. Keith Sopha started his career in housekeeping management in 1974 at St. Michael's Hospital in Toronto, Ontario, Canada. In 1980, he established Good Choice Cleaning Services Incorporated, a contract cleaning service specializing in healthcare cleaning and consulting service for the cleaning industry. Throughout his career, he has participated and led several support services and initiatives, including President of the Canadian Association of Environmental Management, Preceptor for Ontario Hospital Association's Environmental Services Level 1 and Level 2 correspondence courses, Environmental Consultant for the Provincial Infectious Diseases Advisory Committee, Environmental Best Practices document released in 2009, second edition released in 2012, and is working with the team developing the third edition. He was part of the leadership team which developed the Environmental Best Practice Educational Toolkit for the province of Ontario, member of the Program Advisory Committee for the development of Centennial College Healthcare Environmental Management Program, co-leader of the Canadian Hospital Environmental Services Study through Queen's University, and co-leader of the Hospital Environmental Cleaning Time Standards Study, also conducted through Queen's University. Keith has been published in Sanitation Canada magazine, the Infection Prevention and Control Canada Journal, the American Journal of Infection Prevention, and presented at many seminars and conferences, including live webinars. He's the founder of Clean Learning, a training and certification program being used internationally for the cleaning industry. So without further delay, please join me in giving a warm welcome to your session leader, Keith Sopha.
Thank you. Thank you. Thank you very much. Thank you, Pamela, and thanks for being here. I appreciate the opportunity to share some of the research we've been doing in the field of environmental cleaning. It's interesting, through my role as president of the Canadian Association of Environmental Management, I've been fortunate enough to be able to work on certain researches. And every time we get involved in one of these research projects, it kind of changes the way you look at things. And just recently, as I checked into the hotel here in Vegas, I looked out the window and looked below, and I saw a rooftop below me. It's quite a nice membrane white roof. And on the rooftop, there were 5 individuals, a cleaning team. Now, certainly, I'm not an expert on roof cleaning. In fact, I know nothing about roof cleaning, but it sort of caught my attention because I saw these 5 individuals as team members on the roof. And about 20 minutes later, I looked back out the window and I didn't see them get very far from what they were doing. So I'm going to share what I saw and then let you know that when we're going through these programs, there's opportunities for efficiencies. So there was 5 individuals. 2 of them had mops, so just your standard mop. There was only 1 bucket, and the bucket was on the other side of the roof, which was probably maybe 30 feet away from them. 1 person had a hose, which was hosing down the rooftop. The other 2 were on their iPhone or BlackBerry or whatever it was. So the work continued for a few hours, and I think the roof is finally done. I've been here since Saturday, and the roof is done. But lessons learned. I really wanted to jump out the window and yell to them, the International Sanitation Supply is just down the road here. You might want to call your team together and look at some equipment out here, because even a pressure washer would have made that job a lot easier. They were working hard with the exception of the iPad, but in any event, I shared that because in our time study project that I'm about to share with you, there were lessons learned as well. So I share that. So today we're going to talk about the phase 1 and phase 2, where we're at in the Cleaning Times project. And this is a healthcare facilities project in Canada. So our first introduction is to recognize the leadership team. Dr. Zoutman is the Chief of Staff at Quinte Healthcare in Ontario, and he's a research microbiologist and specialist in infectious diseases at Queen's University. Doug Ford works through Queen's University, and he's the analytical guy. He's the guy that takes information, tabulates all the information, and makes some sense out of it for us. Of course, myself as president of the Canadian Association of Environmental Management, representing our cleaning members in Canada. And as part of phase 2, the introduction of Brock Wiley, who is a consultant who owns a program called Clean Measures. So that's sort of the leadership team that has been taking the project forward. So why do we need to look at how much time it takes to clean? Why do we need the answer to this? So in Canada anyways, and maybe in some other countries, and maybe here in the US, there's a general lack of knowledge regarding the length of time needed to clean rooms and cleaning tasks in Canadian healthcare facilities. There are a few benchmarks available. We researched, we looked out there, to tell us exactly how much time it takes to clean a hospital room based on best practice. So what data exists is not specific regarding the hospital room type, the cleaning procedures, or any isolation precautions. So this study will determine benchmarks for terminal cleaning, daily cleaning for routine of private, semi-private ward rooms with and without isolations. So that's the intent. And then the other purpose of this, in 2009, PIDAC, which is the Provincial Infectious Diseases Advisory Committee, raised the bar for environmental cleaning in our hospitals. This document, 155 pages of how to clean our hospitals in Canada, was released in 2009. The second edition is in 2012, and we're currently revising the third edition. So this is a team of experts in Ontario, physicians, infectious disease specialists, and a few environmental managers who helped develop the standard for the province of Ontario, which quickly found its way across Canada. So from our CHESS study, I mentioned that I've been involved in a few studies. CHESS is the Canadian Hospital Environmental Services Study, and this was a 3-year research project that we conducted from Canadian hospitals based on, we wanted to look at the links between environmental cleaning and hospital-acquired infections, and we wanted, though I thought it was a question, scratching his head. So the CHESS study, a few items came out of that particular survey and study that we did. It was a 3-year research. More than half of the environmental service managers indicated that they did not think they had sufficient staff to clean hospitals based on the standard. Pretty scary thinking that, maybe you or your loved one has to visit a hospital. Less than 40% of the hospitals are sufficiently cleaned for infection prevention purposes. Another scary statistic out of that research. So we know that there's some variables that impact standard benchmarks. But one thing we do know is that if we really work hard enough on this project and put enough effort into this research, we should be able to narrow down precisely, or at least a good range of how long it takes or how much time we should be allocating for staff to clean based on best practices. So what are some of the things that impact? I put a few up here. The room type and size. So obviously, if the bigger the room, it may take a little longer to work your way through. The age of the facility may have an impact. Some may argue that the older facilities are harder to clean than new. Again, that needs to be determined. The facility design, where you're starting and wayfinding. The geographics of the building that you're cleaning. If you're in a let's take weather conditions in northern Canada. Lots of slush and snow coming in obviously impacts the cleaning times. The activity in the room. So what's going on in terms of patient care, patient treatment during the cleaning. Clutter, the more you have to work around, it's obviously very difficult to do. So I point this out because we know that there may not be a precise number to say this is the number for a certain clean, because you have to consider some of these other factors. But we will, by the end of this, have a benchmark. So part of the study, we wanted to look at what was out there in terms of standards to date. And there's very few published information based on industry cleaning times for hospital cleaning. That's just the reality. They're generally aggregate and non-specific to a patient room. But we do have some numbers. There's between 25 and 35 minutes for occupied and 40 to 45 minutes for terminal based on the Center for Disease Control standards. The International Sanitation Supply has an excellent booklet for cleaning times, provides more information in detail or aggregate time studies, so very specific, how much time per square feet in a room, you add it up. So they're coming out about 14 and a half minutes to 16 minutes, and they were established, we understand, back in 1993 or earlier. And they're item-specific cleaning. It's not the whole start to finish based on the new standards that we established in Canada. And Canada produced viable data, the National Productivity Improvement Program, but this is 1985. I think the PIDAC best practice standards raised the bar and raised that question, do we have enough time to clean? So back 1985, they, without a washroom, 12 and almost 13 minutes, and for an occupied patient room, and 21 or almost 22 minutes for patient room with an adjacent bathroom. So just to put it on the graph to give you an idea, so right there, just on the stuff that we know, there's already a pretty interesting range between 12 and 25 minutes for routine cleaning. And the data is kind of dinosaur. I mean, somebody went out there with a stopwatch many years ago, and not questioning the validity of the data, but the reality is we have to do something different. So let me tell you about our method of phase one. Phase one, and incidentally, we weren't planning on two phases. Every time we start a research project, it's always interesting how things evolve. So phase one, we created with a team of environmental service experts. We got them together and said, let's ask some questions about times required to clean and make sure that we get it right. And we'll create a survey and we'll send it across the internet to our colleagues in healthcare settings. And we wanted the surveys to be completed by senior managers, environmental services in these hospitals. And we narrowed the benchmark to facilities with 50 beds or more. And they were acute care facilities. We did find, though, that there was a real interest in this time study. When we announced at our caem conference 2 years ago that we were doing this, there were long-term care facilities said, what about us? Mental health facilities, the same, and so on. So some of the preliminary results for 33 healthcare facilities that we were able to take the data and compare and analyze. So at this time, we realized that there wasn't enough information from the long-term care and the other healthcare type facilities like mental health to be able to add them to this particular study, but we're getting there. So the second round of survey, we're going to do a second round of surveys in phase 2, and I'll explain why. So we had to ask some other questions as well. We wanted to find out patient areas, according to these environmental services, are they cleaned according to the public or published recommendations? And when we said that, we knew that we didn't want to specify PIDAC because in other provinces of Canada, there's other types of standards. However, the standards are very similar because PIDAC sort of was the foundation for some of the other ones out there like PICNIC, etc. So we asked the question, are you cleaning according to recommendations? And 27 of the 33 hospitals said they always do. So that's pretty good. I mean, if it's true, that's a good thing. And 6 of the 33 were probably a little more honest and said that they often do. Remember the chest study that I referred to, that the majority of environmental service managers out there that responded to our study indicated that they didn't believe that they had enough staff to sufficiently clean to best practice standards. But according to this data, they're saying they are, so that's a good thing. So how hospitals determine room cleaning times is another important factor for our study. So here on this particular slide, you'll see a mix of questions, and they were able to respond to more than one. So for an example, 25 facilities rely on past experience. So you know what? It took 10 minutes before, it should take 10 minutes now. So you know, I'm an expert, of course it only takes 10 minutes. 16 facilities conduct time and motion studies. So they actually got a stopwatch and actually measured it. 11 individual or facilities use individual task times. So they, like ISSA, how long it takes to clean each item. The aggregate industry time standards was 5, and workload software. And this was kind of surprising because there's so many workload software programs out there that help us determine workloading, but only 3 of those 33 facilities actually use a software program to help them determine how much time it's required to clean the room. And like I mentioned, they could use a combination of all. So here's some stats that we got out of phase 1. We found that private room takes about 17 minutes to clean, 24 minutes for a semi-private room, and 38, and this is routine daily cleaning. This does not include isolations. It does not include any additional precautions. So routine daily cleaning. And all the hospitals that surveyed used a single person to do it. They didn't work in teams. They worked basically independent on their own. Now, this is a standard deviation chart that just indicates, I'm going to flip quickly to the next slide to explain what that is, because I've got a couple of these. And this comes from our experts from Queen's University. So I don't know if you can, no you can't. So if you look in the yellow section in there, there's about 68% of the data collected. So what it does is you look at the standard deviation, the measurement, the disbursement of the data. So if somebody, let's assume the standard is 10 minutes in the average. If we're all falling in there between 12 and 14, it's in the yellow. And anyone out to the pink that maybe put 2 hours, or someone that does it in 10 minutes or 1 minute, they sort of skewer the data. So we separate those and we work within the standard deviation to come up with proper, measurable, and credible standards. So the industry benchmark for routine cleaning, when I showed you the first slide, it's rather interesting to look at because we said we raised the bar in terms of the expectation to clean. And I really didn't see too much of a range in here. when you look at the yellow, the blue, the red, and the green, other than the fact that in Canada in 1985, it was 14 to 16 minutes, and now we're saying it's 17. Interesting data. So time to perform discharge transfer of cleaning per patient room, we're averaging around 32 minutes for a private room, 41 minutes for a semi-private room, and 61 minutes for a full ward. And we couldn't narrow it down to a 3 to 4 bedroom ward. 8% of the hospitals used 2 cleaners for the discharge transfer of the semi-private rooms, and the 15% used 2 cleaners, so worked to clean the wards. And there's the standard deviation of in terms of 20 to 60 minutes between the private room and semi-private room, and a larger range with the wards from 30 to 126. So we asked how much time to perform routine cleaning under isolation precautions, excluding C. difficile, the spore that takes a little more time to kill and process. So it was 29 minutes for a patient room, 39 minutes for a semi-private, and 54 for a ward. So this includes, we're hoping, the whole process of donning and doffing, etc. And there's the standard deviation. So again, it's important to know that from a statistical point, that the standard deviation range validates the outcome of the stats that we're able to pull together through Queen's. Time to perform routine daily cleaning under isolation precautions due to C. difficile per cleaner. And a private room, we're looking at 36 minutes, 46 for a semi, and an hour for our ward. 2 hospitals used a team of 2 individuals for routine cleaning under additional precautions for C. diff. And there's a standard deviation. The frequency of cleaning CDI rooms. This is interesting too, because 18% of the 32 facilities said they cleaned it daily, and 82% said they did it twice a day. Now, if we look at the PIDAC recommendations to routine cleaning of a patient room due to C. difficile is twice a day. There's 2 steps cleans, but there's also twice a day. So during a regular shift, the morning and afternoon, that room should be cleaned and disinfected twice. But 18% of the respondents only do it once a day. So it raises the question again of whether we're cleaning to standards. The method used to clean CDI rooms, so cleaning and disinfecting in 1 step there in the red, 59%, and cleaning and disinfecting in 2 steps. Now again, the PIDAC recommendation is that we should always clean before we disinfect for C. diff, so it should be a 2-step. However, we do recognize that some sporicidal disinfectants have the cleaning properties, and I hope that that's why it fell into the 59%. So they're using a product that cleans and disinfects as a sporicidal. Then daily routine used to clean floors. We thought this might have an impact on the time. We wanted to know, are you dust mopping and wet mopping in 1 application, or are you doing it in a 2-step? And 84% of the hospitals do a 2-step, so they dust mop and then they wet mop. Particularly for changing privacy drapes, whether they're soiled or through isolation. 10% of the respondents do not use ladders. They have very tall people in their facility, and I gather or they have one of those probably clip-off. You've ever seen those Velcro types? Just pull off. And 90% use ladders. And there's some interesting stats here, because to remove a curtain is almost 9 minutes, and to replace it's almost 12 minutes. So it's a significant amount of time. And some of this information, again, we have to look a little closer, because we don't know where the ladders are or where they're getting them and how much downtime, et cetera, as we go. but we're learning as we move. And we looked at the standard deviation around there, which was pretty significantly close. So here's what we've shared to date with the information. At our CAM conference, at Canadian Association of Environmental Management, we shared in 2014 some preliminary results of phase 1. We just recently, last month, had a conference in Niagara Falls, and we shared this information. We had a poster presentation at the Infection Prevention and Control Conference in Victoria, BC in 2015. Our study has been accepted for publication in the Canadian Journal of Infection Control, and results have been presented to the PIDAC committee for review, because we're hoping that when we narrow this down, that we might reference this in the PIDAC document, which has a lot of clout in our industry, particularly for those individuals that are openly admitting that they don't have the resources to clean based on best practice. That's the intent. That's where we're going with this. So more to share. We've been approached by the UK Journal of Infection Control. They're interested in our study. They want to publish. ISSA presentation here today, and yesterday I did a short little quick clip on where we're at with the study. And the Ontario Public Health Conference, where we're putting an abstract in Toronto for 2016. But through the study, it's interesting how things evolve. The study raised another question. Is the data that we're receiving time allotted, or is it the time required? Remember that slide that I said, where we determined how they figured out, I'm an expert, so you get 10 minutes, that slide? Is it the time being allotted? You say you're getting 10 minutes, or do they really need 12? We don't know the answer to that. So that raises another introduction of phase 2. And we brought our colleague Brock Wiley on as the principal auditor for our facility, or for our project. And we developed a plan to survey cleaning practices in a variety of hospitals. So now we're going a little broader because there's interest out there. We want to include acute care, complex continuing care, mental health, and long-term care. And we want to know, is there a difference? And I don't know the answer to that. I think I have some hint, and you probably have a good opinion of that, but we want real, valid, solid data that supports this. Oops. All of a sudden went fancy. So the time study tools in the past, maybe you've used those and they're okay, was the old stopwatch. This is what we're looking at with our time study right now. So we're actually going out to facilities, and Brock has this system. You can't read a lot of that, but I'm going to try to explain. So on your right-hand side, the red, those are indicators of time. So basically, on the far left is step-by-step what they should be doing based on best practice on routine cleaning of a patient room, step-by-step working their way through. Brock is doing observation audits and clicking the stopwatch on the computer as they go. And you'll see a couple of gaps there. That's because they didn't do the task that was situated on there. So this is interesting. This is what we're finding. The data collected indicated inconsistent cleaning practices. These are our colleagues that said, sure, come into my home, look at our facility, meet my staff, watch them clean, and this is what we're finding. And we're also finding that the time that they're spending in the room isn't 17 minutes, it's less. We're saying they need 17. In fact, we're finding it's less than the 1985 standard that we put there. And part of it is because of interruptions in cleaning. They're not cleaning based on best practice. And this is not a blame. This is not a criticism. This is reality, and I'll talk a little bit about that. So the conclusion is, as part of phase 2, we need more audits, we need more site participation, and we have sites that are willing to participate in Canada. And certainly we'd be interested in partnering here in the US as well. I think the hospital cleaning times in the US should be very similar, if not exactly the same as Canada. We need financial support to continue our research, and we're looking at grants and or sponsorships. So if anyone's out there that's connected with any of our large distributors, suppliers, manufacturers that are interested in supporting us, we'll be happy to work with you. So I have a few minutes to share some of the outcomes that we found outside the things that interrupt and basically mess up the cleaning times. So this is a mental health facility that allowed us to come in, and we witnessed this. The linen bag in the top corner there is what they call a knitted fitted sheet. And a knitted fitted sheet just sort of stretches over the mattress, the first sheet. If you're in the healthcare business, you know what I'm talking about. But the central laundry that supplies these, basically several years ago, to save money and to be efficient, went to the knitted fitted sheet because they don't have to go through those high pro twin folders. Makes sense. But this is an interesting find, because as we watched the housekeeper clean, she opened up this bag, and in the bag is 10 knitted fitted sheets. 6 out of the 4 knitted fitted sheets went back in the wash because they didn't meet the hospital standard on the bed. And I'll show you some things there. So you probably can't see the detail there, but the 2 staff members up there, there's a big mark, a big tear in the item, big stain, tape. This isn't the laundry problem. This was the facility problem, and it's a hospital-wide problem because the hospitals are the ones that are marking these things up with the tapes, etc. So just from that one observation audit, this particular facility spends pretty close to $200,000 a year on linen costs, just to process the linen through this. If they eliminated that or did something better, they would be able to reduce the linen costs and maybe put some resources into cleaning. So some other benefits of the process, we did see some of these things. Now these are real pictures, and what happened was we ended up seeing a housekeeper that was participating in the audit was working on a floor that she wasn't familiar with. But that shouldn't have made a difference because cleaning is cleaning, and the hospital room looks the same, night bed tables, all this stuff. So the routine should be the same. But what she found was she was spending most of her time looking for the tools to do her job. So this particular cart here that you're looking at on the left and the top was concerning. Too much product was jammed into the cart, couldn't find what she was looking for. We had standard. You keep clean on one side and dirty on the other, and we've got a woolly wonder or duster there that's hanging over top of all the microfiber cloths. So what we did is we went back to that facility, we met with the housekeeping team and said, why don't we have a standard cart? Use the tools you have, let's organize it. So we got a group of about 8 or 10 housekeepers in the room, and we pulled them together, and they came up with this. And all of a sudden, the duster tool is better, it's down rather, it's away from everything else. They organized the cart, less disruption, and it's all the same. So if I'm a housekeeper going to a different unit, I just open the door and there's everything organized and so on. So efficiencies can be gained. So at the beginning, I talked about variables that impact room type and size, age of the facility, design, geographics, activity in the room, and clutter. I still agree but there's other things that affect the benchmarks in terms of quality and time. Systematic cleaning. If individuals are trained to systematically clean from one corner of the room to the other, routine cleaning based on best practice, you will ensure that the room is clean to standard and you'll get it done quicker. Tools and equipment. There's lots of suppliers out there with new technologies and innovation to make their job easier and more efficient. Interruptions. When we showed that slide where they couldn't do things, we had housekeepers going in the room and 15 people in the room because of the time that they were going to clean. We've made changes in the healthcare sector, at least in Canada, in terms of visitations. At one time, I don't know if, at least I can remember many years ago, there were visitor times between 8 or 6 p.m. and 8 p.m., and that was it. Now they can come and go whenever they want. It was good patient care, but the problem with that is the housekeeper can't do his or her job because they're working around people. And how they clean impacts. If they're cleaning systematically is one thing, but how they clean is another piece of the puzzle. So there's a lot of information that has sort of evolved from our study. And basically, in summary, we're finding that if you take the time to really watch and do observation audits with your housekeeping team, you will discover opportunities within your organization, things like those linen costs, etc. So in saying that, I thank you again for your ears, and I welcome any questions that you might have. And don't be shy. Oh, just in the back. Can you wait for the mic before you speak, please, so I could hear it up here as well? Thanks.
Is your presentation going to be available?
Yes, there's a couple things. The statistics that are here, I mean, ISSA, I believe, is interested. They can post it on their website if they do that. The statistics and more detail of some of their findings is actually on the CAM website, the association website, on my personal LinkedIn. And if you want it, come to we're exhibiting here at booth 3388. Come see me, I'll give you a card. I can email you the poster presentation, which gives you all the data. Okay.
I had a question over here. Two questions. First, the data that you provided had a lot of Canadian research. Is there a crossover to the U.S. that's comparable, or would they also be interchangeable?
Well, that's an interesting thing. I don't know if there's any studies going on in the U.S. at the moment, and how if it is, how it's being coordinated. But the answer to that is we'd be interested in doing U.S. study. Our association is Canadian and we're national, but we see value in working with our industry partners. So if there's any opportunity for us to work with our U.S. healthcare facilities to get this data, we'd be willing to do so. And again, the only difference may be we'd have to look at the standards. The PIDAC best practice standards, I believe, if you look at the references, they reference CDC, they reference everything that's out there worldwide, and the U.S. is certainly a big part of the data that we use to establish the standard. So I don't know how that would impact the data, but we'd be willing to work with anyone. So if you want to come see me, we could chat. All right.
I actually had a second question. You had touched briefly on C-Def and cleaning and disinfecting in the rooms. C-Def in some of my healthcare facilities is a big concern with cleaning practices. I don't know if you can answer this question, but in what method of C-Def, maybe in Canada, is being used without corrosion issues and other things that come with addressing that issue?
Yeah, that's an interesting question. I'll leave brand names out. I mean, there's, I think we know that there's peroxide-based products. We know that there's chlorine-based products, and there are new technologies that are coming out every day that are having less of an environmental impact. There's issues around odors, particularly with some of these products. It's a personal thing. But from the environmental perspective, I know one facility in Ontario that was using a chlorine-based product that had to change. It's a brand new facility, and they showed me, this was just 2 weeks ago, they showed me hundreds of thousands of dollars of damage in a 3-year brand new facility based on a product that they were using routinely, not just for, it was a sporicidal, but they were using it every day. And it's because this particular facility had a huge C. diff outbreak and lessons learned. People died, so they went to the extreme. They didn't want anyone else to get sick and die again, so they used the sporicidal for routine daily cleaning. And in less than 3 years, there was an environmental impact. But the good news is there are new technologies out there. And we hope that as they get perfected, it'll be better to the environment, more effective for spores, and keep us safe. But we just got to keep supporting our research, and you know. So I don't know if I answered your question. You know, it's a tough one. Take a look around. As long as it has a, I think the FDA approval here in the U.S. for sporicidal. I'm not sure. Make sure it has the proper the certifications that you need, and try it. You know, sorry, but that's all I can say. It is an issue.
Yes, Doctor. I'm wondering if you have or plan to use at all the UVC in your time study, the ultraviolet.
We did not, because we're doing cleaning time studies, but we know that ultraviolet technology is one of those new technologies that is having a positive impact on the environment. And then there's pros and cons. I mean, ultraviolet light is proven to kill certain microorganisms. There are different types out there that have different times associated with them. So no, the answer is we haven't gone that deep yet, but we can. And then there's some vapor technologies that are being tested as well, that we know that takes about an hour to particularly make a room sterile, a 6-log reduction, and this is in research stage right now. So there's new technologies that are helping us battle these things. One of the issues in hospitals is when the patient is leaving, there's a tremendous pressure on housekeeping to get that room ready for the next patient. And time is real important. So we could look at more technologies. We'd be willing to, but we didn't include them in this. We're looking at the actual physical cleaning. I have enough for another question in the back.
Hi, Professor. Thank you for your research. I'd like to know, based on your research in Canada, is there any effects of the cleaning time on the cross infections in the hospitals?
Sorry, is there any difference between which?
Between the cleaning time and the cross infection rate.
Oh, okay. That's interesting because as part of our new study, let me just have a look here. Let me just go back here. Oh, I just connected, doesn't matter. We plan on phase 2 to collate some of the cleaning times and outcomes with VRE, MRSA, and C. difficile rates. So we're hoping to be able to see that if we invest the appropriate time into proper cleaning and disinfection, will we have a reduction in these types of microorganisms? So that's in phase 2 as planned. Okay, thank you very much.